Thanks for joining us again at the Canadian Breakpoint, a Canadian infectious diseases podcast by Canadian infectious diseases physicians. I'm Summer Stewart, here with Dr. Rupeena Purewal, pediatric infectious diseases physician in Saskatoon. For today's episode, we invite Dr. Alison Fox-Robichaud to discuss sepsis and some of the important sepsis initiatives that her team is involved with here in Canada. Dr. Purewal.
Perfect. So welcome to another episode of our podcast, the Canadian Breakpoint. Today we have a very special guest with us. It's Dr. Alison Fox-Robichaud, who, as many of you might be aware, has done a lot of work around an important topic that we're going to be discussing today, which is sepsis. So to give a formal introduction, Dr. Fox-Robichaud is a professor of medicine, the Hamilton Health Sciences Chair in Sepsis Research at McMaster University, and a critical care medicine specialist, head of service for the critical care response team, and the director of medical education at Hamilton Health Sciences. She's also the scientific director of Sepsis Canada. She has over 160 peer-reviewed publications reflecting broad academic interests, including animal models of sepsis, translational medicine, health services research, and clinical trials. A leader in the critical care community, she was the first female president of the Canadian Critical Care Society from 2015 to 2018, and the first female chair of the Canadian Critical Care Examination Board. Well done. Internationally, she's also a member of the Global Sepsis Alliance Board, the Advisory Board of the International Society for Rapid Response Systems, the Council of the World Federation of Intensive and Critical Care. She is the organizing chair of the 17th World Congress of Intensive and Critical Care to be held in Vancouver this September. She's been honored nationally for her work in electronic early warning scores to prevent patient deterioration and received the King Charles III Coronation Medal for her national sepsis leadership. Internationally, in 2018, the Global Sepsis Alliance awarded her an individual award for her sepsis leadership. So as you can see, we have an expert with us today, and we're really fortunate to have you today.
Thank you very much, Dr. Purewal, for inviting me to speak on your podcast. I'm honored to be here.
Thank you. So, I've been wanting to talk about sepsis for a while, just because it's, as we all know, a very important topic, something we as healthcare professionals of kind of nurses, specialists, if you're at the forefront, even family doctors, pharmacists, critical care physicians, obviously, are always involved in. And so I think there's a lot of information that has changed or is ongoing. There's a lot of research in this area. So I think for our listeners and also for myself, it would be nice if we could maybe start with the basics and let's just define sepsis. So how is it diagnosed? Are there clinical criteria? And are these being applied in clinical practice?
So I'm going to take it a step back. I think when sepsis and the word sepsis has been around since the Greeks, they called it poisoning. And recognized that it was a condition with a high mortality when, people got an infection, got really, really sick with it. But the modern definitions have changed. And I really think that intensivists have gotten too smart sometimes in terms of that's been our biggest community. We are, this is our disease, and I'm going to call it a disease.
Yeah.
We've been calling it a condition, a syndrome, but I'm going to call it a disease, same way as oncologists call cancer a disease, because I think that's important for the audience to understand. And it means that it's a disorder that affects how your body functions, right? It's more likely to have a known cause. And in this case, the known cause of sepsis is infections. And more likely in a distinct course. That is, there is a pattern to this. And the pattern for sepsis is organ dysfunction. That varies based on what the pathogen is, whether it's bacterial or viral or fungal, the host factors, whether your immune system's up to par or not, and some environmental and probably social factors that may make some individuals, more at risk than others. And it has some established treatments, maybe not enough in our field, But that definition now culminates in something that we call life-threatening organ dysfunction due
Mhm.
to a host response to that infection.
Right.
So it's really driven by how our body responds to infections. And some people can have an infection and not get sick at all.
Mhm.
And other people get organ dysfunction that ends them up in our ICU.
Yeah, so really a clinical like spectrum that we
Yeah.
see. So are there some key warning signs? Because sepsis can obviously, deterioration can happen very quickly. So are there any distinct warning signs? Or like you mentioned, there obviously are risk factors. So you know that individuals are predisposed or may be predisposed to having this. But are there anything that physicians can look for or kind of use?
I think this is probably our biggest challenge.
All right.
So, unlike a heart attack,
Mhm.
where we have biomarkers, you come into the hospital, you do it. We don't have the same thing for sepsis. So, there's a lot of it depends on patient intuition.
Mhm.
Something's wrong with me. I seek help. I've not felt like this before. And a
Mhm.
lot of it depends on clinician intuition. This is an infection. But it also depends on doing some measurements, the simplest of which is, are your vital signs normal?
Mhm.
So are things like your respiratory rate, your blood pressure, your heart rate. Now, young people can hide that away sometimes, and elder people may not get a fever, but those abnormal vital signs that include confusion. Our patients, when they tell us about experiencing sepsis, can say it feels like everything from, I'm not thinking clearly, I can't make urine, I've got a nausea and vomiting, through to, I just feel horrible and I'm not sure what's going on with me.
And then I know like in the past, there's obviously some like vital sign parameters that we can use. So
Yeah.
like if somebody has, a really elevated temperature, very low temperature, that could be in correlation if they have a really fast heart rate, as we see with that. So some of those criteria are being assessed at that time to kind of see if this patient is currently as critically ill as we think they are.
I'm part of the upcoming Surviving Sepsis campaign guidelines, and one of the things is looking for those diagnostic tools. May not have great biomarkers yet, but we have that constellation of our vital signs put together into some things such as early warning scores. And some of my work, I say, why is she working on early warning scores for patient deterioration? It's because I know that that's one of those things to pick up those early signs of this infection is affecting the whole body and my body's ability to maintain homeostasis. And that may show up before you have measurable organ dysfunction, creatinine rising, O2 sats falling,
Right.
platelet count dropping.
Yeah. And I guess like we mentioned some of the or like you mentioned biomarkers in general. So in my world, I think in some of other hospitals too, of some of the listeners that are tuning in today, there's a few that are commonly used, I would say. So like procalcitonin in certain centers is being used now, even sometimes more frequently than CRP. And obviously CRP's like historically been used a lot. So what are your thoughts on this? And I mean, obviously, we have to interpret medicine from like the patient and their clinical
Yeah.
standpoint, and we shouldn't be using a lot of the diagnostic criteria, but they're supporting evidence in certain situations. But what do you feel about that?
So let me start with most of the biomarker, diagnostic biomarker work in
Mhm.
sepsis is unfortunately been done in the critically ill and
Mhm.
not where 80% of the septic patients present the emergency department. Probably the last time I wrote a little study on this was only about 11 studies.
Mhm.
May have seen the headlines in the Globe and Mail this week that our colleagues and some of our colleagues in the network in Toronto have think they've got this panel of genomic markers
Yeah,
that
I saw.
may have, and that they're working on this lovely device that. So there are some signals from genomics, but I think we need a quarterback sort of pull all of this together. So if I talk about procalcitonin, the evidence for procalcitonin is probably strongest in the patient population you look after, which is the neonates. And there's at least one really good study that shows that tells me whether I really can continue the antibiotics or I can stop the antibiotics.
Right.
Similarly, in the adult population, it tells me I can stop antibiotics because it's less likely to be a bacterial infection. Unfortunately, people haven't transitioned their practice to actually do that when you go back and look at, has that been translated? It's not so great in the diagnostic end because it has some bacterias don't cause an elevated procalcitonin, and it's lousy for viruses and for fungal infections. Similarly, CRP, well, CRP is just running the rounds of who's going to use it, the latest biomarker. The cardiologists were using it for a while.
Hmm.
Now we're using it, but it's an acute phase reactant.
Yeah.
So it goes up, like fibrinogen goes up and albumin goes down. So it really just tells you you've got an acute inflammatory reaction that's been turned on.
Yeah.
And so people are looking at pancreatic stone protein and other markers in the inflammatory cascade. And we've been doing some work because we understand that coagulation is intimately linked to this inflammatory response from the very earliest stages. So we've actually been looking at some coagulation markers that may be equally important. And
Hmm.
surprisingly, it's not their going up that's important, it's their going down that's important.
Yeah, no, that's fair. And so I guess economically, so I know some centers don't have procalcitonin because it
Yeah.
is a little bit more expensive, as I find in kind of talking to microbiologists and other lab techs. And so how does that kind of, I guess, impact which biomarkers are in which
Yeah. I
institution?
think many centers are now using CRP because it had been used by the cardiologist. So it's a good rough screen that just says, you know what, this person's got an ongoing inflammatory reaction and we've got organ dysfunction. And maybe we've got to go looking for other markers of coagulation or other things that may be disrupted that says there's an ongoing immunothrombotic, there's a new word for people perhaps, where the immune system and the clotting system have been overactivated as part of the response to infection.
Got it. Yeah, and so it's a good thing you mentioned it's more of kind of a spot test, I would say, instead of some people are using procalcitonin and trending it, and I always find that very difficult to explain because it really isn't a trend. Like I don't think that we have good information in terms of its clearance from the body.
And
And
and there haven't been a lot of studies that look at it mostly as a spot check in
right.
terms of its
Yeah.
diagnosis.
Okay, fantastic. Yeah. And so going back to obviously our sepsis and the disease that we're talking about today. So I mean, the important things, and I think you have seen this in your clinical world a lot, is, the acute kind of complications that you can get from this type of disease, and why we're talking about it and why it's so important to identify. So, do you have any shared experiences that you want to share today with our audience in terms of some of the both either acute or long-term consequences, just to kind of weigh some light or shine some light on this disease?
Well, let's talk the acute. The most common cause of sepsis in North America, at least, is pneumonia.
Yeah.
Still the most common cause. In many parts of the world, sub-Saharan Africa, for example, it's diarrheal disease. But
Hmm.
in North America, it's pneumonia. We still see urinary tract infections leading to sepsis in the elderly, bad intra-abdominal infections, whether it's your gallbladder or your appendix,
Hmm.
can lead to that. And skin infections,
Right.
right? So skin infections, diabetics from some work that we've done are not necessarily at increased risk, short-term risk for getting sepsis, but there's long-term complications of diabetics having sepsis. Yeah.
Yeah, and so definitely, I think the acute deterioration and the multi-organ dysfunction are some of the challenges that you guys probably
Yeah.
see.
Oh, like supporting organs. So,
Mhm.
certainly the organ support that we do, ventilators. So people on ventilators, long times on like months on ventilators. I've got young patients, young people who've ended up with Legionella.
Mhm. Yeah.
And then that's a bad one because the liver fails, the kidney fails. And we've seen a rise in Legionella in the last little while. I'm not sure people are cleaning out their ventilation systems
Yeah.
or. Right. And then the other one that we're seeing is a lot of rise in Staph aureus.
Mhm.
And this is the worst year I've ever seen for group A strep. So
Yeah.
skin-based infections, like it's just a bad season. And I get all the notifications for the contact tracing in the hospital, and yet another group A strep contact tracing,
Yeah.
right?
Yeah. We've seen an uptick of that too.
I can't recall in my sort of 25 years as an attending in the ICU that I've had four, and this year I had four patients with group A strep, two of them very sick, and two of them just with wounds that, whether we caught it early or otherwise.
And I guess one of the things with, like obviously many diseases you want to pick up early. With sepsis, I think we always talk about, starting treatment very early in this condition, right? Or in this disease. And so it has that any of the, obviously there's the early warning signs, some of the vital signs if they're critically ill, and you're thinking about sepsis, we all talk about that golden hour, the
Yeah.
original, where we want to start soon. So in your world, is that something over the years, have you seen less complications since those guidelines have come out, or is that something you guys are working with to see if, is that 1 hour mark ideal?
So certainly Surviving Sepsis campaign says if you're in shock
Hmm.
and you have an obvious source of infection, that golden hour, less than an hour, is really important. If you have a suspicion of sepsis, that golden hour is important. And you know where the source of infection. If you're not so sure, then you've got a little time to wait, do some cultures, wait for some things to come back from the lab. We've shifted from relying on lab work immediately, waiting for that CBC to come back, for example, as like this is obviously they've got a source of infection and they're obviously got organ dysfunction or they're not perfusing, jump on it. Have I seen less? I don't think we have enough data in Canada, particularly unlike Australia and other places, to say we've moved the bar from if you end up in an ICU with sepsis, your mortality rate is still around 20 to 25%, right? If
Yeah.
you're older, it's going to be higher. If you're immunosuppressed, it's going to be higher.
Okay.
Right? And the complications therein afterwards as well.
Yeah. And I would assume that the earlier you start, the earlier you pick up the disease.
Or it's always like the
Mhm.
earlier you pick it up, the more likely we are to reverse the organ dysfunction and be able to get people shorter stays through the hospital.
And so then that leads me to the next point because I first heard about, more the work that you guys have been doing with Sepsis Canada at an AMR antimicrobial resistance symposium that was back in November in Toronto. And, it was really interesting to see because there's this, choosing wisely, making sure that we are using, antibiotics appropriately, because we do have that concern with the growing concerns of antimicrobial resistance as well. So for our audience who, is kind of thinking, we are saying basically you need to treat if there is sepsis and there's the infection. How do you balance that with the growing concerns of AMR?
Ooh. So let's start with what we know between the AMR and sepsis burden. Some great data that's come out of Johns Hopkins and the antimicrobial resistance collaborators. So
Hmm.
if we estimate that there are currently about 13 million deaths due to sepsis globally,
Hmm.
and about almost 9 million of those are due to bacterial infections, then 5 million of those are due to resistant organisms. Okay. And associated or attributable, is 1.5 million. So it's a huge problem. And if we know that within the next 5 years or more, the amount of AMR is going to continue to rise,
Hmm.
particularly in countries in the world who have not had the tight regulation that we have had over many of our antibiotics. I talked to colleagues in India, colleagues in Saudi Arabia, where it's a huge problem, where their first line antibiotics are meropenem and they still have resistance to it.
I know.
Right?
It's terrifying.
So I think, Are we in good shape because we've controlled to a certain extent some of the misuse of antibiotics, right?
Yeah.
Do we have good antimicrobial stewardship programs in our hospitals, at least our academic centers? We do. It helps to say, okay, are we getting evidence like the balance trial that says if you've got a gram-negative bacteremia, you don't need 14 days, 7 days is adequate. So we're not persisting. And some really interesting work coming about being careful about what antibiotics you're using for the most sick because you may be adding to the problem. Some fantastic work coming out of Michigan where a natural experiment where they lost pip-tazo.
Mm.
They didn't have it for a period of time, and they
Yeah.
were only using gram-negative coverage. And in fact, they had better outcomes, statistically significant better outcomes during that period. And so
Mm.
they're now going and looking at this. But, sometimes you don't kill the anaerobes. And I would say pneumonia is probably our biggest gap. Like, don't kill the anaerobes there.
Mhm.
And certain skin infections don't kill the anaerobes,
Mm.
right? They
Yeah.
may, in fact, be beneficial.
Yeah. Yeah. And so definitely, I think, like you mentioned, an important thing is knowing kind of your local system and having, the pharmacists involved. I think like what we've done locally, even if you don't have an established stewardship program, is working with the local pharmacist to create stop dates and that type of thing, which even if you are, worried about sepsis and you're going to start antibiotics, then kind of reminding yourselves that we can follow cultures, you can follow the patient clinically, and getting them off as soon as possible.
And remember, sepsis is the body's response to that infection. It doesn't mean the infection's continuing.
Yeah.
The organ dysfunction may be continuing. You've killed the antibiotics with the appropriate things. You just don't want to add to the antimicrobial resistance problem.
Yeah. So it's a really like I guess fine balance, and why like there's multidisciplinary teams that are involved
Yeah.
usually in these cases. Yeah. Perfect. So moving forward, so you mentioned some of the research that you guys are doing. So what is the future in sepsis research? What does it look like? Are we going to get more information on some of these biomarkers or novel biomarkers, or just overall defining sepsis in general?
So we've done some really great work in the network over the past 6 years. I think we're still working on getting that prevalence across the country. It's hard data. We're relying on two things. First of all, we're relying on discharge abstract data, which
Hmm.
means people have to write that on the chart. If somebody's septic, write it on the chart, please.
Yeah.
And so we're starting to pull that. We've got this conflict between the modern research definition, SEP3, organ dysfunction,
Hmm.
and what we currently use for discharge abstracting, which is ICD-10 codes. We're
Hmm.
not at ICD-11, which gives a little better definition.
Right.
And everybody's had a version of how many codes do you put in. We've published some work looking at probably what is a broader definition for
Mhm.
sepsis, and we're applying that to some Chi-Hi data along with some traditional ones. So look for that coming. The other thing we've done is look at both the costs and the outcomes of sepsis. The cost is staggering.
Mhm.
Even before the pandemic, in the province of Ontario, sepsis cost the province approximately $1 billion a year in Ontario.
Yeah.
And that was only the adults. It wasn't the kiddies, it wasn't the long-term outcomes. And that mortality after sepsis was 50% in the next 5 years. So you had 20% not survive if you're in ICU, another 50% are gonna. And the why of that we're starting to understand.
Hmm.
Part of that why is cardiovascular disease,
Hmm.
ongoing thrombosis, strokes, heart attacks.
Right.
I said that, diabetics are at particular risk. So if you're not a diabetic, that risk in the next 5 years is about 10% for cardiovascular disease after an episode of sepsis. If you're diabetic, that goes up to 40%. So the
Mm.
combination of the endothelial damage that occurs with diabetes gets exacerbated with sepsis and makes your risk for cardiovascular disease even higher. The other thing we've learned is that those survivors of sepsis become the highest cost users, at least in the province of Ontario, based on ICS data, for
Mhm.
the next 90 days, like the top 1%. even after hospital discharge, they cost the healthcare system a lot of money. So I think the next big field
Mhm.
is understanding why that mortality beyond cardiovascular disease, what treatments can we apply,
Mm.
and what impact can we have. So in fact, we're working right now, there's text going on, I can hear them background on my phone because we're working on a meeting grant to start talking about a registry for sepsis survivors. We don't have any way of tracking those survivors afterwards, and many of them have significant cognitive impairment, organs that are barely functioning. I shared a story recently in the media about a young girl who is a quad amputee, and we have a number of amputees who work in the network who have had such bad septic shock that, and with the supports that we have to provide, that they've lost limbs. And
Mm.
that's a big complication.
Yeah.
We're learning a lot about who's being taught about sepsis as healthcare professionals
Right.
and how we might teach even school children. One of my honors thesis students, it just completed a little pilot study with a bunch of high school students and their teachers about sepsis and what they could learn.
Yeah.
So educating the public's really important. Figuring out what the barriers are in the emergency department. We have all of these we have stroke protocols and we have trauma teams.
Mm.
And the evidence for team sepsis or code sepsis teams not as strong.
Mhm.
Literature suggesting maybe if we just improve the performance in the hospitals, we don't need to go to specialized units like we do for strokes and trauma, but that's an evolving literature.
Okay.
And then finally, what tools do we have to treat this?
Mhm.
Predict2's not doing well. We have a serious problem that 30 plus years of really not having any novel therapeutics aside from antibiotics, fluid, and supportive care.
Right.
So looking for novel therapeutics. We've got trials running based out of Winnipeg, where plasma exchange might be. And I know there's people thinking, oh, this is the latest, greatest, but we need to study it and find out if it actually is going to work. I've got
Mhm.
colleagues in Ottawa who are starting a stem cell
Mm.
therapy for septic shock patients.
Yeah.
Colleague today just registered another support. What other ways can we support for blood pressure? You know, there's a double-edged sword for supporting with the medications we use to support blood pressure. Can we use other adjuncts to support blood pressure in the ICU? So
Mhm.
those are some of the clinical trials going on. And then we're really doing some innovative work to try and understand the pathophysiology better as well with preclinical work.
So a lot of work that's,
Yeah,
even though it's been years and years, like this is not
right.
a new disease,
Yeah,
but it's just, I guess, like not very well understood
yeah,
and parts we know of it. But again, like you mentioned, it's a clinical spectrum, right? So
yeah,
not everybody presents the same
yeah,
way.
yeah.
And I think that's probably the challenging part
Yeah,
here.
and look at, if you compare us to the oncology field and how long it took to get precision treatments and more understanding of each individual kind of cancer and what treatments you could or could not use. I think we're behind with sepsis as a disease. Will we get there eventually? I hope so, a coordinated effort,
Yeah.
but it's a similar problem, but just a shorter time frame, right? We've got minutes to hours as opposed to something that's a little more slowly to evolve.
Yeah, that's fantastic. You're doing some really good work out there and a lot of your colleagues. And so it's obviously something that we deal with all the time in infectious diseases. We're working very closely with those that are in sepsis and
Yeah.
septic shock. So yeah, it would be really interesting to see some of the findings of those research projects. So I guess just to end off today, because that was a wealth of information for myself as well, but also for, I'm sure, our listeners that are really fortunate to have tuned into today's episode. So, what's one key message, I guess, that, I mean, there's multiple messages you probably want to send out, but one key message if you want our listeners today to take away from this episode?
I think similar to the thing we're asking our patients to do, we're asking health professionals just to think about this. Educate. We know there's gaps in health professional education related to sepsis, right?
Hmm.
It's not being taught in programs. It's not being taught in a lot of subspecialty programs.
Yeah.
Could it be sepsis? Just ask yourself that question. Could it be sepsis, this unwell patient? And that includes, oh, it's just flu, but could it be flu associated sepsis where secondary infections can occur and where the mortality rate is so high. It's higher than myocardial infarctions in this country, right?
Yeah.
Higher than the top 3 cancers combined,
Yeah.
right?
Yeah. So definitely something that we should be aware of
Yeah.
and also be.
Yeah. And for those, the family docs who see on one end, but particularly after end, like think about the complications that if somebody says, oh, I came to the hospital, I was in the ICU with my infection, that means they had sepsis. And that means they may need psychological support, extra rehab, other things that we have not considered. We're building this syndrome called post-sepsis syndrome, and it's clear that there are things that these patients have. So on the front end, could it be sepsis? On the back end, what are the complications if you've survived a hospital stay or an ICU stay with a bad infection?
Okay, well, that's really important and really key information. Thank you so much. And we really appreciate you coming again on the podcast, supporting the podcast, and talking about a very, very important topic today. And yeah, thank you for taking the time to do that.
You're very welcome. It was a pleasure.
Thank you, Dr. Fox-Robichaud, for joining us. For links to more information, educational material, and to Sepsis Canada, please see the episode description. Have a topic suggestion? Or would you like to talk about your infectious diseases research? Email us at thecanadianbreakpoint@gmail.com or X us, is that a thing? @CA Breakpoint. See you again soon at the Canadian Breakpoint.